Thanks, everyone. I'm going to review like an introduction to intracardiac echocardiography, which is kind of echocardiogram, but outside of echo labs. Basically, I was thinking just for the reviewing this emerging technology, it's better to have to talk a little bit about history of ICE or intracardiac echocardiogram and describe the initial basic views that we can see in the ICE to grasp a better feeling how an ICE view looks like, and then review some clinical applications of the intracardiac echocardiogram. Starting from the history, the whole idea of ICE actually goes back to about 60 years ago. In early 1960s, someone put a single piezoelectric crystal at the tip of the catheter and thought if they put it inside the body of an animal, they can have an intra-body echocardiogram, basically. By 1969, Bohm developed this tiny 32-element phase array coil, which is I put a picture here, and did actually the first actual intra-body ultrasound or echocardiogram. As you can see, the image is not really great, but it's opened a new door to further development of this technology. The first real inhuman basically report of intracardiac echo goes back to 1981, when Dr. Glassman and Cronzen put this specially designed ultrasound catheter, which connected with a wire at the tip of the right heart catheterization or transesophageal catheter, and put it inside the heart. It was less than a millimeter diameter, and this is one of the first image of like M-mode intracardiac echoes, which were published actually in 1981. By 1990s, with development of the lower frequency transducers, this area of technology improved significantly. In early 1990s, Boston Scientific and Cardiovascular Imaging System are trying to compete in developing the best possible ultrasound, intracardiac ultrasound device. And actually by end of 1990s, in 1999, AccuNav, which is from Siemens Medical, got approved. As you can see, the first prototype was a 24 French rigid catheter. I put the image in beside a temporary, like contemporary catheter that we use right now, so you can see the difference in size. But this is actually the first FDA-approved ICE echocardiogram. With improvement of technology, now we have, to the best of my knowledge, 4 different companies making ICE probes. One of them is AccuNav, which is now owned by J&J. They have 3 different probes, 8 French, 9 French, which are 2D probes, and also the new 3D probes that can have 3D imaging of the ICE. It's basically, there are 64-element transducer. Their frequency is between 5 to 10, and their tissue penetration reaches about 15 centimeters. The other company who has a comparable device is St. Jude, which is now owned by Abbott. It's also a 4-way catheter, 64 elements, similar to the AccuSun, and we use this one in cath lab in St. Michael as well. To compare these two probes together, they are basically similar. One of them 9 French, the other one has 2, 8, and 10 French, both of them. Both use similar frequencies, similar type of transducer with relatively same tissue penetration. However, tissue penetration in the V-Flex extra is a bit longer and had superior image quality, but at the same time, it doesn't have 3D capabilities as AccuNav has. Another probe that used in ICE is developed by Boston Scientific is Ultra ICE Catheter, which is kind of different from the other catheters. This catheter has produced 300-degree like radial image, like ICE catheters. It has this advantage of having a very great, huge field of view, which 3D reconstruction capabilities, but the disadvantage is this catheter should require a guide wire, doesn't have Doppler, and the image depth is only 5 centimeters. As you can see, there is a comparison between this longitudinal 90-degree sector probe image that we can see in phase array catheter in TE, TTE, and ICE, comparing with the 360-degree view of the ultra ICE catheter. The catheter is in the middle of the image here, and these are the surrounding environmental structures in the heart. And very recently, Philips introduced this very site pro catheter, which is like the maneuvers is completely automatic, not mechanical, I mean electronic, and it has 3D and X-plane capabilities as well, with very good quality image, as I saw in the studies, which we will review later. Knowing that we have these 4 catheters, before reviewing the clinical application of ICE, I thought it's reasonable to have an understanding of what are the views that we can see with the ICE catheter, how we manipulate it, and so I have a better understanding what we see and how we can use this new technology in clinical life. When we put the catheter through the femoral vein, going into the right atrium, the home view is basically looking, staying in the right atrium, looking at the tricuspid valve and the RV. At this, which we call it home view. If you rotate the catheter about 30-degree clockwise, you can open the RVOT, aorta, and pulmonary valve, basically aligned with the tricuspid and RV. From the same position, if we tilt the catheter a little bit more clockwise and a little bit leftward, then we can open up something like short axis view of the TEE or TTE, which we can see RALA, interatrial septum, and short axis view of the aortic valve. If we continue to turn the catheter more to 60 to 70-degree clockwise, we can see the mitral valve, LA, and the left atrial appendage, as you can see in the picture. At this at this position, for better visualization of the fossa ovalis, it's just a little bit manipulation to the left and right, and a little bit posterior tilt of the catheter, and you can see a very good image of the interatrial septum. We have to just turn it clockwise enough to get rid of the mitral valve, then we can have interatrial septum centered in our view. From there, if we do a posterior flexion, we can see the SVC basically, which is one of the cardiac structures that we cannot see well in TE and TTE. So this is one of the advantages of the ICE, actually, in terms of visualization of the cardiac structures. Going back to neutral position and turning it more clockwise to about 90 to 100 degree, we can see left pulmonary veins, superior and inferior, and further rotation to about 180 degree, we can see the right pulmonary veins as well. These are the views that we can see when we are staying in the right atrium. But we can also deflect the catheter, bend it forward, and go to the right ventricle. And from the right ventricle, if we turn it toward the interventricular septum, we can have a long axis view of the left ventricle and pap muscles. From there, a little bit manipulation and clockwise rotation will show left atrial appendage and left superior pulmonary vein better. If we deflect it more, we can have a short axis view of the left ventricle as well. As we can move this probe inside the heart, we can go to the RVOT and have a direct visualization of the pulmonary valve and main pulmonary artery. From there, we can have a better look of the LAA if we clockwise rotate the catheter with a little bit of manipulation with right-left knob of the catheter itself. And also we can pass the pulmonary valve and have a better look at the branch of the pulmonary arteries. The other views that we can get with the ICE is basically going through the transeptal to the left ventricle and have a crisp image of the left atrial appendage and left side structures like mitral valve. So having this amount of close view from every single heart structure basically opens a new door to a lot of clinical application for this new device, new technology. It was initially used for ablation of arrhythmias, left atrial thrombus evaluation, to endomyocardial biopsy, a lot of interventional procedure in structural heart disease, basically LAA closure, VSD, ASD closure, and also TAVI, valve implantation, diagnosing of the lead infection and endocarditis related to the device. And also recently, there's a report about left bundle branch pacing guided by the ICE. I thought it's reasonable to review literature about these applications and see what we stand right now. With respect to ablation of the arrhythmias, initial studies and reports of using ICE in ablation of arrhythmia goes back to early 2000s. There are a lot of study and a lot of reports basically about AF ablation guided by ICE, understanding the different left atrial structures based on the ICE and helping with the ablation procedure. However, with the development of electroanatomic mapping and 3D reconstruction technologies, the use of ICE with that respect reduced a lot. In 2017, Dr. Razminian in US published this 5-year experience using ICE not to replace the electroanatomic mapping, but actually to replace the fluoroscopy in EP lab. They had almost zero fluoroscopy experience for 5 years. They basically reported the 500 consecutive cases that they did with ICE guidance. And as you can see, in all these 500 cases, there were only 20 seconds use of fluoroscopy, which was for actually venous access confirmation, not for the rest of the procedure itself. And they basically reduced it to 0. At the same time, the risk of complication in their series is comparable, if not better, than the previously reported complication of these arrhythmia ablations. And they used ICE for ablation of different arrhythmias, from simple ablations like AVRT, AVNRT, to more complex ablations like VT and atrial fibrillation. The risk of recurrence that they reported in their series is also comparable to the previous reported recurrence rate of the ablation procedure. So basically, they showed that with use of ICE, we can almost eliminate fluoroscopy and radiation without basically compromising safety, efficacy, or procedure duration. Another meta-analysis, which was published in 2022, confirmed the report of Dr. Razminian. And it says, it showed basically that use of ICE will significantly reduce the fluoroscopy time, the procedure time, and it does not affect complications or efficacy of our procedures. One other area that ICE can excel is checking for like left atrium or left atrial appendage thrombus during the procedure. Because if we have this situation, we need to call the echo lab, bring someone, ask someone to come and help if they're available, do a TE to find out if there is any thrombus in the left atrium. However, with the ICE, you can do it during the procedure without need for anesthesia, without need for echocardiography, colleague, or any other devices. However, the initial reports of using ICE to visualize the left atrium and left atrial appendage was not really promising. In 2010, There's this report of 95 patients with history of AFib who were undergoing right atrial cath, and they did ICE versus TE in all the cases, and they showed that ICE was actually less sensitive in visualizing the left atrial structures, including the left atrial appendage. Having said that, this is an older study, and the technology in before 2010 was not that great. As you can see, the image quality of the ICE in their studies is not optimal. Recently, in January this year, ICE-TE study was published. They assessed the patients undergoing atrial fibrillation ablation, and they divided into two groups. Some of them had TE before the procedure to rule out LAA thrombus and LA thrombus, and in others, they do ICE at the time of the procedure. There were more than 2,000 patients in this study, and they showed there is no change. Actually, there was a very good visualization of the left atrial structures. There was no difference in terms of complication reported. Actually, there was more post-procedural fever in the TE group, which is expected because of the general anesthesia that we usually give while the patient doing TE. And the risk of a stroke was comparable. There were 3 cases, none of them related to the left atrial thrombus. And interestingly, they found that the length of hospital stay was shorter in the ICE group, not because of the procedure itself, but because of the waiting time for arranging for TEE, and also if the patient needs anesthesia. One of the other applications of ICE is endomyocardial biopsy. If you would like to biopsy a certain structure, not do a random biopsy of the myocardium, ICE would be very helpful. In this report, basically a 55-year-old man with history of past medical history of melanoma and seminoma, presented with this right atrial mass. They did a cardiac MRI, tried to delineate what this mass might be, and they showed that the mass invaded the interatrial septum, base of the interventricular septum, and also aortic root, but it could not differentiate what the mass is probably. So with an ICE-guided biopsy, they put the catheter, they visualized the mass, they put the biopsy catheter on the mass and did the biopsy from it, which was shown to be melanoma, unfortunately, in this case. Going to the area of the structural heart disease intervention, this is the area that ICE really excels. Having a close look of intracardiac structures and diminishing the need for general anesthesia was actually a huge improvement in terms of using ICE. For example, for intraatrial or interventricular septal closure, ICE can be very useful. And there were a lot of studies comparing ICE, reporting the successful use of ICE in these procedures. However, all these studies from the Experience Center, despite all these studies from the Experience Center, shows that there are great success with ICE. It reduced the hospital stay, it reduced the need for general anesthesia for the procedures. But it was not really obvious that on a general scheme, like in the whole, in the countrywide procedures, is ICE that useful or not? So reviewing the nationwide registry of the Japanese Structural Heart Disease Registry, they showed they had between 2015 to 2020, there was nearly 3,000 cases of the ASD closure. To be exact, 2,859 cases, which were done, some of them with ICE only, some of them with TE, and in some cases they need to use both ICE and TE. And comparing these two together, it was found that there was no significant difference in terms of complication, in terms of in-hospital deaths or procedural deaths, or the device success rate. However, there was a significant reduction in need for general anesthesia in patients who underwent ICE, and there was no difference in procedural time. as expected, because the ICE has a huge learning curve. So when we look at it in non-experienced center, it actually might delay the time of the procedure, and the fluoroscopic time in ICE was actually longer than the fluoroscopic time in TE group. One other area of structural heart disease intervention is TAVI, which is like developing around the whole world with a rapid pace. And ICE would be really helpful in delineating the aortic valve and guiding the procedure, basically. One of the studies, which was not really new in 2011, and after that, all the studies basically confirmed the results, showed that they used like randomized 50 patients, 25 to ICE, 25 to the TE group, and they basically showed that use of ICE has some benefits. It has better, you have a better picture of ascending aorta, you have better visibility of the coronary ostium with ICE, and because the ICE catheter is not as big as TE catheter, you can do the continuous monitoring, and there is less need for repositioning of the catheter because it does not interfere with the fluoroscopy, basically. For the valve-in-valve procedures, I'm not aware if there is any kind of randomized trial, but there are a lot of reports for using ICE-guided valve-in-valve procedure. For example, in this one, there's this 77-year-old with previous MVR, AVR, and redo AVR, which were very high risk for the procedure, had a degenerated mitral valve. And they used the new 3D ICE to guide the procedure. They implanted a new mitral valve, did the procedure on local anesthesia, and basically the patient discharged on the same day. As you can see, these are the images that was gathered in this procedure. The first two images shows the degenerated valve with the amount of turbulent flow across the valve, and also degenerated leaflet in image B. And these are the image of the post new valve implants with mean gradient of only 3. One other application of ICE is left atrial appendage closure. So we use Watchman for and other devices for LAA closure under the TE guidance, basically. And the reports of LAA closure with ICE guidance is actually a little bit conflicting. In an earlier study, which was assessment of national readmission database collected from 2016 to 2018, they found out that actually using TE was associated with less major adverse events, which include in hospital deaths, pericardial effusion, cardiac arrest, or hemorrhage requiring transfusion. It was also associated with lower length of a stay in hospital with lower cost. But as expected, ICE need to be done in experienced center, and there's a learning curve. So if we use all the national basically data, probably it's expected to have less success with use of ICE in the procedure. However, the recently published ICE LAA study used ICE in 100 patients for LAA closure. This is a new study with newer technology. They had a very good image. It was done in experienced center, and it was actually a multi-center study, but in all of them were experienced centers. And they showed the device success was 100%. Technical success was 100% in these procedures. The procedural success was 96%. So there were 4 patients who was not defined as procedural success, 2 of them because of groin hematoma and 2 of them because of access site bleeding, nothing related to the device itself. The end point in this study was paravalvular leak more than 5 millimeter after 45 days, which was assessed by TEE of the procedure. And then, as you can see, there was no single more than 5 millimeter leakage in these group of patients. However, there were a few cases of between 3 to 5 millimeter leakage, and there is like 22 patients or 23 patients who had less than 3 millimeter leakage. With respect to complication in 45 days, there was one case of mortality, which is not related actually to the procedure or may not be related. It was a cardiac arrest 10-day post-procedure in a patient with history of cardiac arrest, CKD, coronary artery disease, and a stroke. And there were 3 cases of bleeding, which has happened on the day 2, 4, and 10 of the procedure. So nothing with respect to like device embolization happened or anything related to the device thrombus. Comparing the results of ICE LAA study with Pinnacle Flex, which was the original study of the Watchman, which was about was done about on 400 patients guided by the TE. You can see the complications were not worse. I mean, they were comparable. There were no significant difference between complications with respect of use of ICE versus TE. And as this VeriSight Pro of the Philips catheter developed, the 3D, we can do it like the Watchman and LAA closure, Watchman implant or LAA closure under the 3D guidance of ICE. This is a report using VeriSight Pro. They did the transeptal with Explain and 3D reconstruction, and they also interrogate the LAA using the 3D images and put the closure device in it, and it was a successful application of ICE. The other area that ICE can be useful is understanding the lead endocarditis. As we know, finding vegetation on the lead can be very difficult in TTE, and TE sometimes it definitely give a better image, but it's not like optimal, and it's not always conclusive. So in this study, they a center who did device explant basically checked all 152 cases of the device possible infection explants with ICE and TE, and they show they categorized the patient with based on the Duke criteria, having definite endocarditis, possible endocarditis, and rejected endocarditis, and they showed that actually ICE was better or more sensitive in finding the smaller thrombus. Sorry, the smaller vegetation on the lead. Basically, in the patient with definite Duke endocarditis criteria, ICE was positive in all of them, but TE was only positive in 73 patients. And the vegetation that was showed by ICE was actually smaller than the vegetation that could be seen in TE, which is expected. Putting an image of the same patients from the TE and compare it with the ICE, you can see this small vegetation is better seen on the ICE images. There are other multiple studies showing the usefulness of ICE in finding the lead vegetation as well, which for the sake of time, I did not review all of them. Going to the last application of ICE, it's Intracardiac Echocardiography guided implantation of proximal left bundle branch block pacing, left bundle branch pacing. For LBB pacing, actually, we need to go to the heart, try different area, put a pacemaker lead, and see what the QRS looks like and if we are capturing this bundle. But this group came with this clever idea. They did ICE in patients who were undergoing PVC ablation. They tried to find, like with the electroanatomic mapping, finding where the left bundle branch is, and then with ICE, you finding some landmark in these patients. And then using that landmarks in 100 patients who were supposed to have pacemaker, they used ICE using that landmark to localize the area that they have to put the pacemaker lead in. And they actually find using ICE would increase the success rate of LVV pacing, would increase the number, decrease the number of attempt times, because usually we do multiple attempts until we find the correct spot. This kind of narrowed down the area that we are going to try, and the fluoroscopy duration was lower in this procedure. And the QRS duration was actually narrower in the group that they used ICE for pacemaker implantation guidance. Basically, to summarize, this is a new technology. It has its own learning curve, which is one of the disadvantages of the ICE. It's a expensive disposable probe, so make most of the center to afford only 2D probes, not the 3D probe. There is more venous access because we need another venous access for the ICE. So it adds a little bit to the procedure. And also, if you want to go to the left side, there is a bigger hole in the left atrial septum. So theoretically, it can increase the risk of iatrogenic septal defects. But at the same time, there is a great amount of application for this new technology. Overall, it reduced the radiation. It reduced, or if not say eliminate, the need of a general anesthesia for most of these procedures. It shortened the procedural time and improved the cath lab turnover. And also, it will help guiding the transseptal access itself. With respect to the costs, although it's an expensive disposable probe, but it reduced the risk of anesthesia and echocardiography team. So basically, the costs will be probably comparable. I would appreciate if anyone from the audience and all the staff have any comments or any question or have any experience using the ICE in their practice to share with us. Thank you.
Thank you, Dr. Darabi, for reviewing this particular topic. It's very comprehensive. It's great to see that it can be used in multiple areas, and together with other presentations that were given in the last 2 months, including the ones with TEE used in the intraoperative environment, and also the critical care, as well as POCUS, and also now ICE, we see the democratization of echo outside the echo lab. So it's actually now being used everywhere. And many of our colleagues are, like, including our interventional colleagues and now electrophysiologists, are using cardiac ultrasound to aid in their work. So, you know, it's, for generations, we spend a lot of time as echo lab people to help out with the structural, but I understand with Tether, right now, they don't really need us because they can do it with fluoroscopy and also ICE as well. And same as some of the closure procedures. So, you know, in some ways it frees up our time and to do this. Do you know anything about the relative cost of these things? Like, are they in the hundreds or thousands of dollars per catheter, and are they reusable?
So there were some basically centers that they reported re-sterilizing the probes and they reuse it. But at least in Canada or in St. Mike, we do not reuse these catheters. With respect to the cost, in this national-based database, I do not know the exact cost of the ICE probe itself, but when they compare the cost of the procedure overall in the TE group versus the ICE group, the ICE procedure was roughly around $5,000 more than the TE group procedure, because it was like $29,000, $30,000 in the TE and about $35,000 in the patients who underwent the ICE. But that 5,000 includes the ICE probe, probably, I don't know, use of experts, use of the devices, and also less use of anesthesia. So I don't know how much is actually the price of the ICE catheter itself.
So you're trading one cost for the other, but definitely there will be less people in the cath lab when you're using ICE. So because the operator can do the ICE themselves, and then you don't have to have a whole big echo machine, TE probes, and anesthesiology in the same room. So there's some advantage to that, and not to mention the challenge of organizing all these people in the same place at the same time.
And the other thing is actually less radiation, not to the patients or the procedure, like the interventionist, but also to the other thing. One less echocardiographer or less anesthesiologist in the room, which means healthier echocardiography team, anesthesio with less radiation exposure.
Yeah. So do you see that all the structural cases like mitral clips or tricuspid clips or TTBR or TTMR, they could be actually done by ICE in the future? Right now, it's all guided, obviously.
I'm not definitely the expert to say that, but it seems that everything in the cath lab will be guided by ICE in future.
No, that's one direction. Okay, let's open up the discussion to my colleagues and see if other people have questions.
Farzad, that was a great talk. From a practical standpoint, obviously, if it's to guide intracardiac procedures, whether it's EP or valvular heart disease, who does the imaging versus the procedure? Can one person do both the image guidance and the procedure, or you need a second pair of hands and eyes to do it together in conjunction?
So based on my own experience, when you're doing something simple like transeptal access, one person can do it because you put the probe in, you have the view, and then you do not need to manipulate the probe during the procedure. But in more complex cases, probably someone else needed to be there and help. But most of the time, there's more than one operator during the interventional procedures. So I do not know like if the same team can handle that, or if there's need for another added person to just handle the ICE. At least in the EP lab, we did not add any other person. It was the fellow or the staff using the ICE and doing the procedure at the same time.
Yeah, thanks. That's probably similar for structural heart disease as well, I would suspect. And then the debate is, as Dr. Chow mentioned about the move of using ICE for structural heart interventions. Is there still a role for the echocardiographer who now does the intraoperative Ts? Are they going to be doing the ICE imaging? In which case they're not going to be located at the head of the bed, or is it going to be the structural heart team, either interventional cardiologist or fellow or interventional cardiac surgeon for that matter? And that's a moving field, particularly for cardiologists who've kind of made their career in structural heart Ts.
Yes, agreeing with you. I think the only caveat is it's not just doing the procedure, it's getting the image, it's also interpreting the image as well. So that's, I think, the part that learning curve is huge. And because most of the interventionalists or EP teams does not know how to interpret a perfect, for example, a device for ASD or a perfect device for a VSD closure. So I think there's still a knowledge gap in terms of appreciation and understanding and interpretation of the image of the ICE as well. So we still probably, at least at this point, I think we need the echocardiographer expertise. Yeah,
no, I think I would agree with you. Having said that, I think our colleagues, at least from the interventional cardiology side, are getting much better at interpreting TE images because of their experience, right? So it's a team approach. But I think the echocardiograpers who are involved, I can speak for Geraldine, I think she would probably still want to continue on, even if these procedures are guided mainly by intracardiac echo. So thanks for the talk.
Thank you.
Yeah, I suspect it will be quite some time before ICE can actually replace entirely the the transesophageal echo right now with the structural guidance for mitral clip and TTBR and that set of things. Basically, you require a lot of the multiplane reconstruction, the 3D, and the interaction. And so not only just crossing the intra-atrial septum, so it requires a lot more on the machine. So I don't think ICE can actually give all that at this point, especially the 3D side of it. Although technology is keep evolving, and there's always, like when I first started with like being aware of this field, the challenge is actually when you image inside the heart, you're actually missing some views that you cannot get when you're coming out from behind. So it's like, stepping backwards allows you to see more and everything all together than actually being inside the audience, for example.
Yeah, no, I agree with you fully, Qiming. But I also agree with you that what we thought was not possible in the past have now become possible. So I think ICE will continue to improve. But you're right. I think that because the imaging of ICE will predominantly only be on the right side, I can't see it moving necessarily into the left heart for thrombotic reasons primarily, and maybe complications. The fact that the esophagus is posterior to the LA and is better for imaging the left heart structures for the left-sided interventions, it might be a little bit better. So maybe we'll continue to have that advantage. And on the flip side, the technology for TEs are going to get better, I think, with catheters that cause less trauma, for example. Probes that cause less trauma and are better tolerated by patients. I think that will help on the TE side as well. So it's kind of competing advanced specific technologies.
Yeah. So I think, this is one great highlight of our field being never boring. There's been some prediction, I think, Howard would sort of agree at some point about 10 years ago, there was some saying at the international meeting, it's like, well, echo is coming to an end in terms of development. It's kind of like, we come to a dead end, but guess what happened? We're still moving forward after so many years. All these new.
Qiming, I had a question. It's Bob. Farzad, you mentioned the early ICE had a very, the penetration wasn't that deep. It was like, I think you said 5 centimeter was kind of as the maximum. So the newer probes, how far, what sort of depth can you get with them? And this whole issue of right side versus left side, obviously, if you're in the right heart, you're getting great images locally, but further away the left heart, what kind of penetration do you get with the newer ICE devices?
So basically with the AccuNav catheter, the penetration is about 15, 16 centimeters. And with the ViewFlex Extra, which is the St. Jude probe, Abbott probe, it's about 20 centimeters. Based on the fact sheet of like a specification sheet of the company, it's 21 centimeters.
And maybe a little bit more about the learning curve. When they talk about, do they talk about number of cases, that sort of thing? And are they talking about people that are already highly experienced in transesophageal? What is the sort of a standard or accepted learning curve to be highly proficient at ICE?
So to be honest, I'm not aware of that, but I think it definitely dependent on what type of procedure are you doing with the ICE. For something simple like transeptal, there's a very small learning curve because you don't do anything, you just put the probe there. It's just navigating the probe through the IVC to reach to the heart, and then clockwise and a little bit of posterior tilt, and you can see a clear view of the interatrial septum. But for like explain 3D reconstruction of mitral valve, I cannot imagine what the learning curve and how many cases needed to be done.
So they haven't actually developed standards like for echo, there are standards for number of cases sort of thing that one would expect to have completed before the feeling is you're fully trained. So they haven't done that for ICE?
I'm not aware of that, to be honest.
Yeah, I'm doing a quick review on the internet. You're right, there's actually no guidelines on performance of intracardiac echo, unlike transesophageal echo, stress echo, or other echo modalities, or even POCUS. So that's interesting. That's a potential field for some professional organization to work on this area.
And I guess my final question is, cost is a big issue, obviously, here in Canada. I mean, each probe is how much money, and has that changed over time? And many of these things get cheaper over time, right? As they, more competition and their ability to make them, gets refined. They're cheaper to make. So is there sort of they used to cost $5,000, now they cost $3,000. Is there sort of any sense for that? Because cost, obviously, if these things were $100 a piece, we'd have a lot of them in the lab, right?
So for ultra ICE catheter, the 360-degree view that we don't use, basically the cost is not that much. The cost in like 10 years ago, it was around $1,000 per probe, and now it's around $250, I think. But for the other catheters, like the VeriSight Philip catheter, the 3D one, I don't know how expensive it is. I can Google it right now, but it should be very expensive, I can assume.